You've probably been told that when it comes to a serious brain disease, there's not much you can do, that once the diagnosis comes, the path forward is simply about waiting, managing, declining, that the medical system will hand you a pamphlet, maybe a prescription, and send you home with very little else. But what if that picture is incomplete? What if the research, from one of the most respected health institutions in the country, tells a very different story? One where the right team, the right strategies, and the right knowledge can genuinely change the day-to-day experience of living with one of the most misunderstood brain diseases of our time? What if the part no one tells you, the part about what can actually be done, is more hopeful than you've been led to believe? Stay with me, because today we're going into the part of the conversation that almost never happens. Not the diagnosis, not the fear, but the practical, grounded, research-backed truth about what life after a frontotemporal dementia diagnosis can actually look like for the person living with it and for the people who love them. And there's one section, about 2/3 of the way through, that I think is going to change how you think about caregiving entirely. Let's start with what's true and what's nuanced. The National Institute on Aging is clear on this. There is currently no cure for frontotemporal dementia, and no treatment that has been proven to slow or stop its progression. I'm not going to soften that or talk around it. You deserve the honest version. But here's what that same research also makes clear. And this is the part that gets left out of too many conversations. There are real, meaningful, evidence-informed ways to manage the symptoms of this disease, ways that improve daily life, ways that reduce caregiver exhaustion, ways that help people with FTD maintain connection, dignity, and function for longer than many people expect. And the difference between families who find those tools and families who don't, that difference is enormous. So let's talk about what those tools actually look like. After a diagnosis of frontotemporal dementia, the research tells us that people and their caregivers may work with a team of specialists, not just one doctor, a team. This can include physicians and nurses, but also speech therapists, physical therapists, and occupational therapists. Each of them brings a different lens to the same challenge. And this matters, because frontotemporal dementia is not one thing. It shows up differently in different people. The most common form, behavioral variant FTD, primarily affects personality, behavior, and judgment. Another major form, primary progressive aphasia, affects language and communication. And other related disorders affect movement first. Each of these requires a different approach, different strategies, different specialists at the front of the room. Here's where most people get it wrong. They think managing a brain disease means managing medication. Full stop. Find the right pill, adjust the dose, and the rest figures itself out. But the research paints a much more complete picture. Medication is one tool in a much larger toolkit. And for many of the most difficult daily challenges, the behavioral changes, the language struggles, the movement difficulties, non-medication strategies are not just helpful. They are, in many cases, the most powerful tools available. Let's start with behavior, because this is where families often struggle most. The behavioral changes in the most common form of FTD, the impulsivity, the social inappropriateness, the apathy, the compulsive behaviors, these are not choices. They are symptoms. And that distinction shapes everything about how to respond to them. The National Institute on Aging offers guidance that I think is worth sitting with. It suggests trying to accept rather than challenge someone with behavioral symptoms. It explains that arguing or reasoning will not help, because people with this form of FTD cannot control their behaviors or recognize that their behaviors are unusual or upsetting. That is not a small thing to absorb. If you are a spouse, a sibling, an adult child, if you have spent months or years trying to reason with someone, trying to explain why their behavior is hurtful, trying to appeal to a version of them that is still in there somewhere, the research is gently, firmly telling you something important. It's not that they don't love you. It's not that they don't care. It's that the part of the brain responsible for self-awareness, for empathy, for impulse control, that part is being affected by the disease. And no amount of reasoning changes what's happening biologically. This realization doesn't make things easier emotionally, but it can make them more manageable practically, because when you stop spending energy on arguments that cannot be won, you have more energy for the things that actually help. The research suggests several practical approaches. Maintaining a regular schedule reduces confusion and helps with sleep. Reducing distractions in the home environment can make a real difference. When someone shows apathy, a loss of interest in activities they once loved, offering specific choices rather than open-ended questions is more effective. Instead of asking what they feel like doing today, offering a concrete choice between two specific options gives the brain a more manageable task. For compulsive eating, which can emerge in some people with this form of FTD, the research suggests supervising meals, limiting food choices, and using distraction with other activities. Securing food storage may also become necessary, not as a punitive measure, but as a genuine safety strategy. And for the caregiver, this is important. The research explicitly validates the need to step away when frustration peaks, taking deep breaths, counting to 10, leaving the room for a few minutes. This is not weakness. This is sustainable caregiving. And sustainable caregiving is what makes long-term care possible. On the medication side, antidepressants, specifically a class called selective serotonin reuptake inhibitors, or SSRIs, are commonly prescribed to help manage social disinhibition and impulsive behavior. For aggression or delusional thinking, low-dose antipsychotic medications are sometimes used. These approaches don't change the disease, but they can meaningfully reduce the intensity of certain symptoms, which changes daily life for everyone involved. Always discuss any medication changes with a qualified physician. Never adjust, add, or stop a medication without that conversation. The right dose and the right drug matter, and that's a clinical judgment, not something to navigate alone. This next detail changes everything when it comes to language-based forms of this disease. For people with primary progressive aphasia, the form that gradually erodes the ability to speak, read, write, or understand language, the treatment goals are twofold. First, maintain whatever language skills remain for as long as possible. Second, build alternative ways to communicate so that connection doesn't have to end when words become difficult. Think about what communication means to the people you love. Think about what it means to you. The ability to say I love you, to tell a story, to ask for what you need, to participate in conversation. When language begins to slip away, that feels like a profound loss. And it is. But the research tells us it does not have to mean the end of meaningful communication. Strategies that have shown real value include communication notebooks, physical albums of photographs labeled with names of people and familiar objects that can be pointed to when words don't come. Word and phrase lists stored on smartphones or computers give people quick access to the things they most need to express. Gestures and drawings can fill gaps where speech cannot reach. And for the people communicating with someone who has primary progressive aphasia, the research is specific. Speak slowly and clearly. Use simple sentences. Wait for responses. Genuinely wait, without rushing. Ask for clarification when something is unclear rather than pretending to understand. These are small adjustments, but they are the difference between a conversation that feels isolating and one that feels like connection. Working with a speech-language pathologist who has specific experience with primary progressive aphasia is strongly recommended. The research makes a point worth highlighting here. Many speech-language pathologists are trained to treat aphasia caused by stroke, and that requires meaningfully different strategies from those used with PPA. Specialization matters. When seeking a speech therapist, asking specifically about their experience with primary progressive aphasia is a reasonable and important question. We're about 65% of the way through today, and this next part is why I think watching until the end genuinely matters. Because I want to talk about something that the medical system often addresses last, even though it arguably matters most: the emotional reality of caregiving for someone with frontotemporal dementia. Not the logistics, not the medications, not the therapy schedules, the emotional reality. Here is what the research and the countless families behind the research make clear. Caregiving for someone with FTD is different from caregiving for someone with Alzheimer's. The personality changes can feel like a betrayal of the relationship. The behavioral symptoms can trigger guilt, anger, grief, and exhaustion, often simultaneously. The lack of self-awareness in the person with the disease can leave caregivers feeling invisible, unacknowledged, and profoundly alone. And because FTD often strikes people in their 40s, 50s, or early 60s, many caregivers are also managing careers, raising children or supporting grandchildren, and navigating a role they never anticipated, all at once. The research does not minimize this, it acknowledges it, and it points consistently toward the importance of finding expert assistance, connecting with support networks, and, critically, not trying to do this alone. There is no version of sustainable caregiving that doesn't include support for the caregiver. That is not a weakness. It is a biological and emotional fact. If you are in this role right now, or loving someone who is, please take that seriously. The person you are caring for needs you to still be standing 6 months from now, a year from now, 5 years from now. That requires you to take your own needs seriously too. Now let's talk about movement disorders, because this is an area where people often assume there is nothing to be done, and the research suggests that's not quite right. For the movement-related forms of frontotemporal disorders, particularly corticobasal syndrome and progressive supranuclear palsy, medications typically used for Parkinson's disease are sometimes prescribed. They don't work for everyone, and when they do work, the relief tends to be temporary and modest. But temporary and modest is not nothing. Reducing stiffness, slowing movement difficulties, and improving balance even for a period of time has real quality of life implications. Physical therapy and occupational therapy play a meaningful role here. Physical therapy helps with movement, strength, and flexibility. Occupational therapy focuses on adapting daily tasks, making the practical activities of life more manageable as abilities change. These are not passive interventions. They require engagement and effort, but the research supports their value. For progressive supranuclear palsy specifically, the research points to weighted walking aids, like rolling walkers with brakes, as helpful for maintaining balance. Exercises can keep joints limber, and for people experiencing uncontrollable laughing or crying, which can occur with this condition, medications have shown meaningful success. For those living with FTD alongside ALS, the progression is typically faster, often 2 to 3 years. Physical therapy remains useful for managing muscle symptoms. Speech therapy can help in early stages. And as the disease progresses, assistive communication tools like speech synthesizers can help maintain some form of expression when speaking is no longer possible. This is one of the most difficult realities in this family of diseases. But even here, the research points toward tools, toward support, toward options. Let me bring this all together now with what I think you most need to walk away with today. First, if someone you love has been diagnosed with frontotemporal dementia or a related disorder, seek care from a team, not just a single physician. The National Institute on Aging identifies specific medical centers across the country with clinicians and researchers focused specifically on FTD. Places like Massachusetts General Hospital in Boston, the University of California San Francisco Memory and Aging Center, Johns Hopkins Frontotemporal Dementia and Young Onset Dementias Clinic, and many others. These centers exist, they are accessible, and their expertise is different in kind from general neurology care. Second, understand that behavior is a symptom, not a choice. When someone with this disease acts in ways that hurt you, challenge you, or confuse you, that is the disease expressing itself through behavior. It is not a measure of the relationship. It is not a reflection of the love that existed. Holding that distinction is hard, but it may be the most important cognitive shift available to caregivers. Third, communication doesn't end when language does. The tools exist, notebooks, phones, gestures, photographs, to maintain meaningful connection even as words become harder to find. A speech-language pathologist with PPA experience can help identify which tools will work best for a given person at a given stage. Fourth, movement difficulties are not untreatable. They may not be fully reversible, but physical therapy, occupational therapy, and targeted medications can meaningfully improve quality of life. These options are worth pursuing and worth asking about. And fifth, perhaps most importantly, if you are a caregiver, your own well-being is not a luxury. It is a clinical necessity. Connecting with other caregivers, seeking counseling, exploring respite care, and allowing yourself to grieve the changes you are witnessing, these are not self-indulgent. They are what make long-term care possible. Research on frontotemporal dementia is moving forward. Scientists are studying new drug targets, refining brain imaging tools, and working to develop treatments that can one day do what current medicine cannot: slow or stop the disease's progression. Clinical trials are actively enrolling participants, both people with FTD and healthy volunteers. Participating in research is one way that individuals and families can contribute to progress that will help future generations. If that interests you, a conversation with your healthcare provider or a visit to the Alzheimer's.gov Clinical Trials Finder is a starting point. As always, and I want to say this clearly, nothing in this video replaces personalized medical advice. Every person's situation is unique. Every family's circumstances are different. The information here is meant to give you a foundation, a vocabulary, and a framework for better conversations with your medical team. Please bring your questions to qualified professionals. And if you feel like you're not being heard, keep advocating until you are. Here's what I want you to carry with you from today. A diagnosis is not the end of the conversation. It is the beginning of a different one, a more specific one that involves more questions, more specialists, more strategies, and more support than many families initially know is available. The disease is real, the challenges are real, and the tools, the resources, and the research-backed approaches to living as well as possible within those challenges, those are real too. You came here because someone you love is navigating something hard, or because you want to be prepared, or because you believe, as I do, that real information, not softened, not dramatized, is more useful than anything else. That instinct is right. Trust it. In the next video, I want to take you somewhere that often gets overlooked in these conversations: the early warning signs that something may be changing in the brain, long before a diagnosis is ever made. The subtle shifts, the ones that are easy to explain away, and what the research says about when and how to pay attention. Because early attention changes outcomes, and that's a conversation worth having. If you want to keep aging with clarity, with information that respects your intelligence, and without the fear that comes from not knowing, subscribe. That's what we're here to build together. Thank you for being here. Take good care of yourself and of the people in your life who need you.